right, everyone, welcome. If you're prepping for your exams, you absolutely have to know Nocardia. So in this explainer, we are going to break down all the high-yield facts you need from the basics all the way to treatment so you can absolutely crush any question that comes your way.
So here's our game plan. We'll start with what this microbe actually is, then figure out who it infects, see what the disease looks like, and finally, cover the diagnosis and treatment. Sticking to this path is going to help lock all this information in for exam day.
First up, let's get to know our microbe. Nocardia has a few key features that you just have to know, and they really form the foundation for everything else we're about to cover.
Okay, the easiest way to remember the basics is with this awesome mnemonic, SNAP. S is for soil, that's where it lives. N stands for Nocardia itself, and you have to remember it's a gram-positive branching filament. A is for aerobic, it absolutely needs oxygen to survive. And P, this is the big one, is for partially acid-fast. This is a crucial identifier. Just with this one word, SNAP, you've pretty much covered 4 potential exam questions. It's that high yield.
Okay, so we know what it is. Now, how does Nocardia actually cause disease? And which patients are most vulnerable? Understanding how it gets in and who it targets is totally critical.
So, Nocardia has 2 main ways to get into the body. Since it lives in the soil, the first route is pretty obvious. Inhalation. You breathe it in, and that leads directly to infections in the lungs. The second way is transcutaneous, which basically means it gets in through a break in the skin. Think about a gardener getting a thorn prick. That's a classic scenario for causing these local skin infections.
Now, here is a classic exam question. Risk factors. Does Nocardia affect just about everybody equally, or does it, pick its targets?
And the answer is a very clear no. Nocardia is a textbook opportunist. For your exams, you have to associate it with patients who have weak cell-mediated immunity. We're talking about the part of the immune system run by T cells. So think about individuals with AIDS, patients on long-term steroids, or organ transplant recipients who are on immunosuppressants. Those are your classic high-risk patients. All right, so now we know how it gets in and who it's looking for. So what are the clinical signs we need to recognize? How does a Nocardia infection actually present itself in a patient?
To make this super easy, just remember the mnemonic LAB. L is for long, which is the most common site of infection. A is for abscess, because this bug loves to spread and form abscesses, especially in the brain. And B is for Braziliensis, which is a key species that causes that nasty skin form, actinomycetoma.
Okay, first up is the lung form. Now, this isn't your typical rapid, acute pneumonia. You need to think of a more slow-burning, subacute infection. It can actually mimic other conditions, like tuberculosis. A key sign to look for is a productive cough with really thick, purulent sputum.
Now, what's really dangerous is when it spreads from the lungs through the bloodstream. And this happens in about half of the pulmonary cases. And where does it love to go? The brain. Forming brain abscesses is a hallmark of disseminated nocardiosis, and it's an incredibly serious, life-threatening complication.
And finally, we have the skin form actiniocetoma. This is a pretty nasty, chronic, subcutaneous infection caused by that direct inoculation we talked about. Clinically, what you'll see is swelling, the formation of multiple draining sinus tracts, and a really characteristic discharge that contains these visible little clumps called granules. Okay, now for what might be the most important section for your practical exams. How do we actually confirm a diagnosis in the lab? This is where you can score some really big points. So collecting the right specimen is really just guided by the clinical presentation. It's pretty logical. For a suspected pulmonary case, well, we're going to collect sputum. For a brain or skin abscess, we'll aspirate pus. And for that actinomycetoma, we absolutely want to collect those crucial granules from the sinus discharge. And here it is. This is the money shot for diagnosis, the modified acid-fast stain. Now, this uses a weaker decolorizer, like 1% sulfuric acid. You have to be able to identify this classic appearance, these beautiful red, branching, filamentous bacilli against a blue background. This picture is the very definition of partially acid-fast. So, this table is your high-yield summary for microscopy. It's perfect for a quick review. On gram stain, you see it's gram-positive with those branching filaments. But the key differentiator, the thing that sets it apart, is that it's also partially acid-fast. Oh, and if you look at the granules in a tissue section with an H&E stain, you might see this classic sunray appearance. Now for culture, you need to remember two key things. It's an aerobe, and it grows very, very slowly. This is super important clinically because you have to specifically tell the lab you suspect nocardia. Otherwise, they might see no growth after a couple days and just discard the plate too early. What you're looking for are these characteristic dry, wrinkled, often orange or pink-colored colonies.
Okay, we've identified the culprit. We've confirmed it in the lab. Let's wrap this all up with the treatment strategy. This is, you guessed it, another frequently asked exam question. If you remember only one single thing about treating nocardia, make it this: cotrimoxazole. This combination of trimethoprim and sulfamethoxazole is the absolute cornerstone of therapy for pretty much all forms of nocardiosis. But for those really severe cases, like that dangerous brain abscess we talked about, just one drug isn't enough. The recommended regimen is a powerful combination: cotrimoxazole plus a carbapenem, like imipenem. And you can't forget the importance of surgically draining any large accessible abscesses. That's a key part of the treatment. Here's another key point for exams: the duration of treatment. Listen, this is not a quick fix. Therapy for nocardiosis is long-term. We're talking typically 6 to 12 months, and often even longer in immunocompromised patients because the risk of relapse is so high. So let's just end with a bit of clinical thinking. We've seen that nocardia is an opportunist that needs long-term drug therapy. What does that tell you? It highlights this crucial interplay between the bug, the drugs, and the patient's own immune system. True clinical mastery comes from understanding that relationship. Keep that in mind, and you're going to do great. Good luck.